Good morning, ladies and gentlemen. I welcome you together with Professor Antoine Flahault to the symposium with the title Health in the Post-2015 Global Development Framework. And I'm Judith Müller. I'm assistant professor at the French School of Public Health. I'm affiliated with the Pasteur Institute, and I'm also vice director in the French network of doctoral studies in public health. The 8 Millennium Development Goals are going to expire by the end of 2015, as you know, and the discussion on the global development framework for the period from 2015 to 2030 has gained great dynamics. And during the symposium, we will see where we stand with the development of this post-2015 agenda. And we will discuss how health is represented in the currently existing outlines for this agenda through specific interventions, by improved health systems, and by integrating health in all policies. Just a few words on the format. We will have presentations, a series of presentations of about 10 minutes by each speaker. We will not have a discussion between the presentations, but we'll have time for 20-30 minutes of discussion on the podium and also with the audience after the presentations. And now I would like to hand over to Antoine to present himself and start with the presentations.
Thank you, Judith. Good morning, everybody. I'm Antoine Flahault, Professor of Public Health at Paris Descartes, Sorbonne, Paris Cité. And when we proposed this session with the London School of Hygiene and Tropical Medicine, and Andy Haynes is representing his school here, we thought this session would be much more an information session or maybe an explanation of the goals, but it's not, in fact, today, because nothing is completely fixed. So this session and this discussion maybe also, in a way, have some influence, or at least we may discuss what are the challenge to be we will have to face in the next months, because in the next couple of months the things will be fixed. So it is a very exciting session we are expecting to have today on these post-2015 goals. So I will just give the floor to Sir Andy Haynes, who is the former Dean of the London School of Hygiene and Tropical Medicine. Is co-chairing the European Alliance for Global Health, Academic Global Health Alliance, and is also a member of the United Nations Sustainable Development Solution Network. So thank you, Andy, for explaining and talking about these great challenges.
Thank you very much. I'm going to really give a very brief overview of the two elements, really, of health in the post-2015 development agenda. One is around universal health coverage, which I'm going to suggest is an important organizing framework. And the second is about integrating health into sustainability. So as you know, health was very much at the heart of the Millennium Development Goals. 18 of the 48 indicators were directly related to health. MDGs 4, 5, and 6 were specifically health-related. Many of the other MDGs were highly relevant to health. But in the post-2015 development agenda, health is there, but it's not as pervasive as it was in the MDG agenda. So one of the questions for us in the health arena is how we can ensure that health is integrated more effectively into the post-2015 development agenda. So, sorry, the screens at the front are not working, so if you could turn those on, that would be great. So this slide really just illustrates some of the goals that have been chosen by the UN High-Level Panel. The UN High-Level Panel is formed of the leaders of Indonesia, Liberia, and the UK, and they came up, after a consultation process, they came up with a number of what they called illustrative goals and targets, and they proposed that there should be a number of transformative shifts, as they called them, that would underpin these goals and targets. And so these transformative shifts include things like issues like leaving no one behind, in other words, eradicating extreme poverty, absolute poverty, but also much closer integration and awareness of the limits to the environmental boundaries which constrain the way in which the economies can grow. So focusing very much more on development that would not prejudice the integrity of the environment. And also about creating jobs that would give employment to a growing young population. So here are the goals that they proposed, and what you can see is that there's really only one goal specifically on health, although there's potential to integrate the health considerations into many of the other goals, including obviously water and sanitation, food and agriculture, energy, and so on. So in the health goal, they really focused on an MDG plus approach. So they talked about ending preventable and under 5 deaths, increasing those who are fully vaccinated. We're going to hear from Nina Schwalbe about vaccination in a moment. Decreasing maternal mortality dramatically, ensuring universal sexual and reproductive health rights, including modern family planning, and reducing disease burden from the diseases that were covered by the MDGs, but also a number of what they call priority NCDs, so the non-communicable diseases that are responsible for the largest disease burden. Of course, there have been a number of other voices as well. There's a Sustainable Development Solution Network that Antoine mentioned, and that's proposing slightly different goals, only 10 of them, again, only one health goal, focusing on many of the same issues, but giving more emphasis, I would say, to universal health coverage. The high-level panel acknowledged the importance of universal health coverage as a kind of cross-cutting, underpinning concept that would help the attainment of these health goals. But they didn't propose any indicators specifically on universal health coverage. You could argue, of course, that many of these goals are intrinsically related to universal health coverage. There's no single goal that measures universal health coverage, but obviously improved outcomes from these range of diseases would contribute to informing us whether we're close to achieving that. But there's, and of course there are other activities around NCDs. There's the 25 by 25 movement, which the World Health Assembly has endorsed, 25% reduction in NCD deaths under the age of 70 by 2025. So that's an important initiative which may feed in, we hope, to the Sustainable Development Goals. But the other dimension of universal health coverage is, of course, financial protection. There are essentially a number of challenges in reaching universal health coverage. One of them is to reduce cost sharing and fees, which are shown on this slide. Also extending from the covered to the non-covered population, and extending from a very limited range of services to a much more complete range of services. Now, the level of those services will depend on political decisions in country, on the amount of money that countries have to spend on health systems. But what is important, I think, is to establish a core mean level of services that applies to all countries, to which all countries aspire to. So the issue of financial risk protection is a very important one because about 150 million people suffer from catastrophic health expenditure each year, which means essentially that health problems drive them into poverty because of fees, sometimes loss of income, and so on. So this combination of factors essentially drives them into poverty. And that can affect people even in middle classes in countries which don't have universal health coverage. Even in the US, it was a common cause of bankruptcy. So it is a very major aspect of universal health coverage, which I would argue needs to be captured by any health-related goals. But of course, health services are only one dimension, and there are many other challenges coming down the road. One of those is climate change, and this slide just shows you the potential impacts of climate change on food production, on cereal grain yields. The red areas are where there's going to be likely to be substantial declines in food production, and they are many of the countries which have weak health systems and already have large numbers of people in food insecurity. So we need to develop policies and indicators and goals which link health to sustainability, and I think they can do that in two ways. One is indicators and policies which both enhance sustainability and improve health, what we call health co-benefits. And the other approach, the two are consistent of course, is to increase the resilience of populations to adverse environmental conditions. So let me just give you a few examples. Air pollution, fine particulate air pollution is responsible, ambient air pollution, outdoor air pollution, responsible for over 3 million deaths a year from fine particles, largely from fossil fuel combustion, coal, other fossil fuels, and of course cars, road traffic, road vehicles, diesels and others. Also household energy, household solid fuels, which are used in many countries, responsible for about 3.5 million deaths per year, premature deaths. And there's some overlap between the two, so some of the household air pollution goes into the ambient, into the wider environment. So low carbon energy sources can reduce fine particulate air pollution. They can reduce greenhouse gas emissions, and in the case of household energy, also black carbon and other climate pollutants. And they can also dramatically improve public health. So I think we need to think about indicators around household energy, clean energy, but also reduced fine particulate air pollution, which is now measured, I think, in over 1,000 different sites. Sustainable cities, another key area, and there's one group that's arguing for a goal on sustainable cities. I don't know if they'll be successful, but there are a number of policies which integrate low carbon, low greenhouse gas emission development and health, such as active travel, walking and cycling, and I've seen quite a bit of that here in Berlin. Road injuries, particularly to pedestrians and cyclists. Fine particulate air pollution I mentioned in urban areas, but also proximity of populations to basic healthcare, primary healthcare, and education. So indicators linking, giving indications of progress on some of these topics could be useful. Urban housing has a key impact on health, and as you know, the MDG indicator for slum housing was attained. 100 million people were moved out of slum housing. The only problem is the actual total number increased because it didn't keep pace with population. So future indicators need to take into account population growth and also some of the aspects of housing that really improve health. I've mentioned indoor energy, household energy, but obviously safe drinking water, electric lighting. It's clear that kerosene lamps now are a major source of black carbon as well as fine particulate air pollution. Replacing them with electrification or solar lamps can improve health and reduce greenhouse gas emissions. Food and agriculture, we have a dysfunctional global food system with nearly a billion people experiencing hunger at the same time as growing numbers are becoming obese and with growing levels of NCDs, many of which are driven by diet. So we need to have indicators and goals that reflect both malnutrition, undernutrition, stunting, in particular in young children, because that affects cognitive performance. At the other end of the spectrum, obesity, but also we need to think about the feasibility of having basic dietary measures. For example, can we collect dietary data in enough countries to make it feasible to have indicators around proportion of energy intake from saturated fat, which is largely from animal products, and it's animal products which are largely responsible for the greenhouse gas emissions from the global food system. And of course, at the moment, we're feeding about 40% of our grain to animals. So that is clearly not sustainable in the long run. And we know also that increasing fruit and vegetable intake does improve health. Water and sanitation, we've seen quite big advances in access to water, particularly in urban areas. But of course, much of that water is not necessarily safe to drink. So having bacteriologically tested, safe drinking water available in the household or very close to it is a very crucial target. And that needs to be resilient as far as possible to climate-related disasters. So in conclusion, I would say that we have to build on the MDGs. We certainly shouldn't neglect what's already been achieved, and quite a lot has been achieved through the MDGs, although there's still quite a long way to go. I think that there are two key elements of health in the post-2015 agenda. One is this concept of universal health coverage, and we need to agree on indicators that would give us a good measure of whether we're moving towards that target, which has really a lot of political support at the moment. And secondly, indicators, goals, and targets that link health to broader issues of sustainability. Because it's becoming, I think, very apparent through the work of the Intergovernmental Panel on Climate Change and a whole range of independent scientists that we are facing a crisis of sustainability. With a population perhaps of 10 billion, we'll have unprecedented environmental change, not just climate, but also acidification of the oceans, loss of biodiversity, and many other environmental changes, which together will pose very grave threats to humanity. So I think it's actually crucial that we both work on health systems, health care, but also these broader issues of linking health to sustainability. Thank you very much.
Thank you for this introduction to the topic. And I would now like to present Nina Schwalbe, who is the Managing Director of the Policy and Performance Department at the Gavi Alliance for Vaccines and Immunization. Nina has over 2 decades of experience in global health, including in reproductive health, TB, HIV/AIDS. The Gavi Alliance has been the main driver for the introduction of new and underused vaccines in lower-income countries. Vaccines, as you have heard right now, is one of the few health issues or health interventions that are specifically mentioned in the current list of illustrative goals of the UN panel that has been published in May 2013. And this is not so much about new vaccines, but about high coverage in all population groups, which makes a link to health systems. And Nina will explain how Gavi works towards this goal and where the challenges are.
Thank you very much, and thank you for inviting me to join you today. Took lots of notes, Andy, on your presentation. So today I'm going to talk about what Gavi's calling the fully immunized child. So child mortality is certainly declining and has reduced over the past 2 decades, which is a success for all the countries and partners who have contributed. But if current trends continue, we will not reach MDG 4 by the end of the MDGs. We need bold interventions to meet this and to meet our global commitment to decreasing child mortality, but it's going to have to go beyond 2015. To reach MDG 4, we need to address the major causes of child mortality. This figure shows those causes. And while neonatal causes remain difficult to address, pneumonia and diarrhea account for almost 1/3 of all diseases. If we add meningitis and measles, we reach 35% of under 5 deaths. We do have the tools to address those, but the question is, can we get the reach? Can we get the coverage that we need to make sure that the children that are currently most at risk have the interventions they need to live? Gavi was set up specifically to focus on the role that vaccination can play. Our mission is to save children's lives and protect people's health by increasing access to immunization. And we do that by introducing new vaccines that were traditionally available to richer populations but not to poorer ones, strengthening health systems, ensuring that the way that those vaccines are introduced are sustainable, and also working with manufacturers to make sure that vaccines are appropriate, affordable, and high quality. Since Gavi was set up in 2000, we've supported countries to protect nearly 400 million children from fatal diseases and contributed to preventing more than 5 million future deaths. We're committed to accountability and transparency and strong partnership with countries, as well as with the international organizations, in particular WHO, UNICEF, and the World Bank. We've had very positive evaluations from our donors, from Australia, from Sweden, from a joint donor exercise called the MOPAN. And we've contributed to MDG 4 and will continue to contribute. We will have introduced pneumococcal vaccines in 30 countries by the end of by 2015. As well as a significant number of countries will have introduced rotavirus. And overall, even in the next 800 days, that will help and contribute to preventing about 350,000 future deaths. The way that Gavi works is we support countries with on the lower end of the income scale, and that means countries that have a gross national income of less than $1,500 per capita. This means the birth cohort served through or by Gavi in partnership with those countries is about 60% of the global birth cohort. By serving this larger group of infants, we have collective buying power. We also have predictable donor funding, which allows us to create opportunities to drive down price and improve supply security. Let me give you an example of how this has worked. By aggregating demand from developing countries and pooling donor support, we've been able to create a viable market where one did not exist before. New market entrants, including from emerging markets, help us to secure supply and increase price competition. This is what the supplier landscape looked like when we started buying vaccines. And by 2012, we had 10 suppliers from 8 countries and have just added a new supplier, or will shortly be adding a new supplier from China, the first vaccine manufacturer pre-qualified from China for a Japanese encephalitis vaccine. So what we've done to do through this model is also strengthen implementation of tiered pricing, where buyers purchase based particularly on their ability to pay as measured by gross national income. Manufacturers now accept Gavi countries as the lowest income on the pricing tier, and as such, vaccines are available to the world's poorest countries at significantly lower prices than to industrialized countries, which stretches country and donor dollars further. A few examples of this is on the slide, and you see blue is the Gavi price, and the purple is, for example, the US market price. And again, for example, with pneumococcal vaccine, what you see is the Gavi countries are paying 5% of the total price. The other critical part of the Gavi model is sustainability. Countries pay a share of the cost of the vaccine. It's not just a donation. This is again determined by their ability to pay, as proxied by their gross national income. Every application submitted for support to Gavi includes signature from the Minister of Finance, a commitment to co-finance Gavi's contribution. Even where that contribution is minimal, just 20 cents per dose, it still ensures the relationship is a partnership, and that the countries, in particular ministries of health, have made the case to policymakers that immunization provides a return on investment. This year alone, countries are footing about $60 million of Gavi's total expenditure, or the total expenditure on vaccines in these countries, through their commitments. This will grow over time, ensuring that we are contributing to the sustainable development agenda. So why invest? Let me give you an example from a recently developed meningitis A vaccine. This was developed through a public-private partnership, and as we see from this simple slide, the meningitis A vaccine costs about 40 cents per dose, but for every case of meningitis averted, that's about $90 of household income. Now, we're not saying that every dose averts every case, but actually, in fact, you can see the message is quite clear. After just 2 years after the pre-qualification of this vaccine, Gavi, through its country partners, has reached over 100 million people in the meningitis belt. So if we look at immunization and the synergies beyond health, we have pretty significant impact. I note that this is from a study, actually not by David Bloom, as is listed in the footnote, but by Stack et al., and was produced for what we call the Decade of Vaccines, a global commitment to increase access to vaccines by the end of the decade. And what we see is lower out-of-pocket expenses, and this is for Gavi-eligible countries alone, the 73 poorest countries, $6 billion in treatment costs averted, less time caring for sick, and less productivity loss for the caretaker, amounting to about $1 billion, longer living, working longer, amounting to about $140 billion of productivity loss, and I could continue. Plus, there are also the benefits to trade and tourism, including fewer infection disease outbreaks and herd immunity. So now to the point of why we're here today, looking beyond 2015. 2015 is approaching fast, and so it really is time to look beyond and figure out how we're going to finish this agenda and ensure access. Gavi believes it's our collective responsibility to eradicate extreme poverty and maximize healthy lifestyles. We believe in the need for a unified health goal that contributes to sustainable development and growth, and that each child should have a chance to strive, every young adult should be empowered to have a healthy lifestyle, and every human should be able to avoid vaccine-preventable diseases. For that reason, we are advocating for what we are calling the fully immunized child. We used to measure the success of the health system and the success of immunization through DPT, a decade-old vaccine which is now reaching the majority of children. Now, still 1 in 5 children is not reached with immunization, but we're still measuring it based on essentially what is delivered as 1 antigen or 3 shots. We believe now that the dialogue has to progress, and all children everywhere have the right to live free from diseases that are vaccine preventable, and that we need the systems in place to be able to deliver those vaccines. This is a measurable and cost-effective development intervention. And it may sound simple, but it's going to take a global effort. At present, we are at about 5% of where we want to be in terms of the fully immunized child. And we're defining the fully immunized child as having been immunized with all of the recommended antigens by WHO. Currently, there are 11 on that list. There are actually more, but we've taken out vaccines that just have a regional indication, like Japanese encephalitis or yellow fever. We've also excluded at this point, in terms of the way we're calculating the indicator, vaccines that are delivered outside of the infant schedule, such as measles second dose or booster shots. So this currently represents the 11. And what you'll see here is in Gavi-eligible countries, even by 2030, with the effort, we'll reach about 70%, we hope. But we also wanted to note kind of what's happening in the rest of the world. And on that note, it's interesting just to give you an example of why is that figure so low. And we have a positive example from Germany, which in the past few months, as I understand it, has made a decision to support rotavirus vaccine. Rotavirus vaccine prevents rotavirus diarrhea, which is a leading cause of death in children in the developing world. But a lot of developing countries have not taken on because it causes morbidity and not necessarily mortality in their countries, even though it is on the WHO recommended list of a vaccine that every child should have. So again, the good news is hopefully we can change the slide now that Germany's adopting both that and HPV. So I couldn't leave the room without also talking a little bit about Germany and the role that Germany has played in Gavi's history. Gavi and Germany's partnership has significantly increased since it first began in 2007. Throughout, up to 2012, Germany contributed about 72 million euros, and this year alone, they've committed 30 million euros, so a serious increase in contribution. It's this type of predictable multi-year funding that we need to continue to market shape and effectively support immunization programs that form part of countries' multi-year plan so that they can plan in the future and in advance for their health systems and how they're going to invest. We welcome Germany's support, and we look forward to taking our partnership with Germany to the next level. We look forward to Germany's G8 leadership in 2015 and the European, which is also the European Year of Development, and for Germany to adopt a strong health agenda for the G8 and for Gavi's upcoming replenishment, as well as we move into the post-MDG agenda, making sure that Germany and hoping that Germany is a strong advocate for the need to include and make the world measure commitment to health. This will help all of us realize the vision that every child everywhere can live a life free of vaccine-preventable diseases. So thank you.
Thank you very much, Nina. So now we will give the floor to Fred Binka. Professor Fred Binka is now the Vice Chancellor of the University of Health and Allied Science in Ho in Ghana. So he has a kind of project of building a charité, Universitätsmedizin, but not in Berlin, in Ho, in Ghana, which is a very ambitious goal. And we know that Fred Binka is a great leader of public health and global health in Africa. He's also the president of the Association of Schools of Public Health in Africa, and is a new coming president of the World Federation of Academic Institutions for Global Health. We are launching this afternoon under the presidency of Fred. So Fred, thank you very much. You will talk about the effort which are done by the countries themselves. We are always talking and often talking about donors, but we have also to think about the countries and the country effort. So thank you, Fred, for enlightening us on that.
Thank you very much, Antoine, for those kind words. I'm not going to use a PowerPoint. I have 4 simple messages to give at the end that are looking at ensuring that the Sustainable Development Goals support country efforts to improve health and sustainable development. So first of all, I think the era of the MDGs will remain a remarkable period in the world's development history, representing a period of global consensus to reduce poverty and improve public health by setting up measurable short and medium-term goals with indicators that allowed us to measure progress. The 8 goals selected reflect not only the areas of underdevelopment, but also underscored the direct relationship between the burden of infectious disease and poverty. The MDGs also created a global partnership between the key health and developmental partners, the bilateral agencies, the multilateral agencies, civil society, and governments in low and middle income countries to make local policies and apply practical solutions to reduce poverty, improve sanitation, water supply, basic education, control infectious diseases such as malaria, tuberculosis, HIV, and TB, and reduce maternal and child mortality. We are a few years to set the date, to the set target date, but there are continued engagements between partners to measure progress and to improve on the delivery of interventions to achieve these goals. However, the most important lessons from the UN MDGs must not be lost on us. I think one of the most important things was the setting of targets, a time frame which was set to 2015 to achieve these goals. In addition, each country had its own trajectory. So there was not a firm target for everybody, but everybody started from somewhere, and we expected them to reduce this, to achieve these things based on where they were. However, it's clear that the measurement of these targets have been a big challenge to most countries in the developing world. In countries where you didn't have the DHS, the Demographic Health Service, or you didn't have the MIX, the Malaria Indicator Service, and so on, there was a real challenge to trying to determine whether they were making progress or not. And in fact, some of these tools or surveys also provided data that was a couple of years late. So these are some of the things that are important. It must be important for us to make sure that we can measure progress and track where we are in the continuum. Reports indicate that most countries have made progress among the 8 goals. In fact, some countries are just about kicking off and getting to their peak. But 2015 is here with us. So we need to look at how to bridge the gap between the current MDGs and the Sustainable Development Goals that will follow the MDGs. And this is where, from the country level, especially from low middle income countries, you start to wonder what is happening. It's sometimes difficult to understand the workings of the global community. We are in a hurry to declare victory and to set up new initiatives. And clearly, we need to make sure that there is a clear link, as Andy just showed us, between the MDG era and the Sustainable Development Goals. One major problem that is going to face most countries in the low middle income countries where this focus was, is even the measurement. What are sustainable development goals? If these things are not well couched out, then it is almost impossible for us to determine whether we're making progress or not. So that's one. Measurements in countries we must apply things in such a way that countries can determine whether they're making progress or not. And we must make sure that, like the MDGs, the targets that we set are measurable and they don't overburden the countries in what they do. Second, the biggest challenge that faced most countries in the MDG era was having these laudable goals, but support and deployment was in silos. There is a need for, even if you take the health-related goals, say reduction of maternal and child mortality and reduction of the burden of malaria, TB, HIV, and AIDS. I think that's the best example. You had the Global Fund that was supporting countries to reduce the burden of malaria, TB, and AIDS. But most of the funding was in silos. You had a TB grant, and you had an HIV grant or a malaria grant, and there was just no linkage between the two. So you did not strengthen the system in a way that allowed us to move forward. So it is important that in this next level, countries are given the opportunity to be able to take these resources and apply them in such a way that the overall effort and the overall impact will be greater than the impact on any one of those identified areas. A typical example in most countries is the health information system. If the TB effort improved the health information system, you could measure the outcomes of HIV and you could measure the outcomes of malaria. But none did that. So we have to rely on what? Surveys to try and measure whether we're making progress or not. So that's one. We need to make sure that the support to country efforts must be coordinated and integrated in such a way that we can address the issues of maybe climate change and all the sustainable development goals that we set ourselves. We also feel that clearly health should be a big component of these new SDGs. And we understand that one of the goals or targets is going to be related to health. But truly, you cannot have development in a population that is not unwell. You must have healthy people to make sure we can achieve the goals that we set ourselves and to sustain development. Secondly, Andy raised the issue about the need for universal health coverage, which was adopted by the UN General Assembly in 2012 as a key global health objective. We do support this, but as he clearly mentioned, it's going to be a challenge to try and determine what is sustainable health development. We think that I suggest that this should be a consideration under the post-MDG targets or the SDG targets, that this should be a framework that allows us to set universal health coverage targets within each of the sub or the major goals. So if you are doing something on maternal and child health, you need to indicate what are the universal coverage targets that you need so that we can measure them. Otherwise, when we have this global thing called universal health coverage, we'll end up not being able to measure any progress at all. Then, I think the third thing that I wanted to indicate clearly is that following up on the universal health coverage, I think the whole issue of supporting and strengthening the health systems. We definitely need to extend the targets beyond infectious diseases to include the new emerging threats in the developing world, which include non-communicable diseases. And once we add that onto our platform, then our health systems become much more the main target or the main vehicle to be able to achieve this. And in doing this, we need to find ways in which we can strengthen the health system. I think at the moment, as I said, all this support has been in silos, and the integration across the various areas that we have determined for ourselves is not so clear. And there must be an effort to help use the expertise that is available to help countries to integrate their interventions to be able to support the goals that we set ourselves. So in conclusion, in the post-2015 era, we must definitely lead to new goals set for the next 2 decades or so. The SDGs must be easily defined. They must be measurable with systems in place to measure targets and to determine the quality of the data that is used to measure this. We must have a big healthcare component only healthy people can assure sustainable development. The current MDGs have provided the necessary global consensus and partnerships to make the world a much healthier place. The SDGs must reinforce the gains and achievements of the MDG era. Thank you.
Thank you very much, Professor Binker, for this comment from the point of view of developing countries. I would now like to introduce Professor Albrecht Jahn from the Institute of Public Health at the University of Heidelberg here in Germany. Professor Jahn has his expertise includes maternal child health, infectious diseases, health policies, and he's leading the unit of global health policies and systems in the Institute of Public Health. And while public health often takes sort of a utilitarian concentration on reducing morbidity and mortality, he will discuss the past and future development goals from the perspective of human rights and right to health. And he will also explain the view of the consortium Go for Health, Goals and Governance for Health. Thank you.
Yeah. Thank you for this nice introduction. Good morning, everybody. I can easily take from where the previous speaker stopped, basically looking at the broader concept and also bringing back a bit, let me say, not the immediate morbidity targets, but also the concept that also the MDGs were basically targeted to promote development. I will also focus on the human rights aspect of it, which you will find in many documents, also in the Millennium Declaration, among others. But I think that it's not just, let me say, something which you can put in the first chapter where whatever you do about health, but that it's also a rather operational concept. Now, as we have partly heard, and I fully acknowledge also the achievements of the current MDGs, but if we look also at the shortcomings, then basically we have just heard there has been not a real impact on health systems. Yeah. There is also sometimes a mismatch of what are basically globally prescribed priority diseases. They don't fit everywhere. The MDGs, that was the major drawback, was despite it was announced as global goals, as something that is for low and middle income countries mainly. And also that it has led to silos that basically per MDGs you had different funding streams and partly parallel structures. So I think these are the main reasons, and I just can continue what has been argued in the previous presentation, to move not to a MDG plus, but to universal health coverage. But in that context, we can really also build on the right to health, and that is my first part. I will briefly want to explain to that. In the first place, the right to health, where maybe many of you will memorize the rather far-reaching overall definition of what health is in the WHO Constitution, in other documents, has developed over time, and there is a substantial body of work and of documents and of also specifications. They are all listed here. I don't go to all of them, but I want to highlight the Covenant on Economic, Social and Cultural Rights, which is probably the document or the convention that is most detailed and also is basically updated. It's updated through so-called comments, and I'll refer also to these comments. Covenant means it is a legally binding document for those who signed, and most of the countries signed this covenant, even in the absence, let me say, of a global court where you could immediately take a country or whoever to court, as you could do in a national system, and where it sometimes happens. Yeah. Now, this International Covenant on Economic and Social Rights is also rather specific about responsibilities. Yeah? It clearly states that it's a state party that has to undertake steps individually in the first place, and then through international assistance and international cooperation to the maximum of its available resources with a view to achieve progressively, this is basically step by step, the full realization of the rights recognized. So it acknowledges you cannot basically, from the start satisfy all health needs, but you should try to achieve them on a step-by-step basis using all your resources. It also, and there are other quotes which I will briefly follow, it also specifically clarifies that there is a primary responsibility with the country or the government, but there is a secondary responsibility for the international community. And it's also quite specific what should be covered. There is one provision of so-called core obligations, and these core obligations are an immediate entitlement. Core obligation means that this stepwise approach does not apply to the core obligations, but this is basically the minimum that should be provided. And this covers access to health facilities, goods and services, especially for the disadvantaged, essential drugs, equitable distribution, and also a national health strategy. There are more core obligations, but due to time, I just picked out the most important ones. What is important at this point in time, that is clear, the right to health is not just a fantasy somewhere, it is also basically realistic in a way, yeah? It says there are core obligations, and the core obligations are not debatable, yeah? It's a right of every citizen of this globe. It is rather specific, as I have mentioned, who is responsible, and there is an international obligation for countries where basically it is known and it is accepted that they don't have the resources to provide especially the core obligations by themselves. Yeah? So there is also a specification who does what, and it tells states that they have to prioritize the core obligations, and that it should be basically the number one agenda item on their agenda. Now, if we look into this framework, which is not just one page, which is really relatively elaborate, especially comment 14, then what can that practically help us in defining new development goals? In the first place, it provides a floor of protection against progressive realization and scarcity. So it gives a clear argument. Scarcity is not an argument a government can use to deny the core obligations. Yeah? Then it also provides a kind of basis for the collaboration between states, governments, and the international community. And it defines, at least, even if not in detail, that both of them have to collaborate, and that the international community in assisting in that field is not just doing that out of charity, but it is based on international law and international right. Yeah? It assists in defining universal health coverage because it defines core obligations and it defines the principle of progressive realization. And that is what Andy has been elaborated in more detail. It also says we have to cover and provide access to health care without discrimination, but also to create healthy living conditions, preconditions or prerequisites. And that is another whole chapter. So the aspects of prerequisites and issues that go beyond the health sector is also covered in that concept. And this is a concept which you see in many of the proposals for the post-MDG concepts, whether it's the 10 proposed goals of the high-level panel or others, that there is always basically this notion, universal health coverage, that is the immediate contribution of the health sector, and then we know that in order to be healthy, you need many other things, and that is a shared responsibility across many sectors. Many of them have been named. Now, you have seen already this slide earlier, so I'll skip that. Will be brief. These are the 3 dimensions, and if it comes to how can we assess universal health coverage, for example, the financial dimension can be assessed by out-of-pocket payments, as has been mentioned. I'll show that. And I also included this one to show the universal health coverage, and that is another advantage, is not really just a problem of low and middle income countries. Universal health coverage is a truly global problem, even in Germany, even in Europe. We have populations group, for example, the Roma population in Europe has a vaccination coverage of 30%. Compare that with the slides you saw from other countries. So it basically puts this issue on the table of every country, and not just as a typical developing country issue. Yeah? So these are here data on out-of-pocket payments within the European region of WHO. So even there you see, or you don't see, but I'll tell you, that there are countries, mainly in Eastern Europe, Central Asia, where 60 to 70% of payments are out of pocket. And even before the crisis, by the way, Cyprus is, oh, of course you don't see that. Cyprus and Greece had already proportions of out-of-pocket payments in the range of 30 to 40%, and now it's even higher. I mean, just to clarify that universal health coverage has really the power to be a unifying theme across all countries. Now, a very brief, let me say, note on what coverage is. Yeah. And then I'll come to how it can be measured. Coverage is originally a kind of epidemiological term, and it tells you to which extent a service that should be delivered to a defined group is really reaching this target group. Yeah. So here the example is obstetric coverage. Of course, you know who should get it, all pregnant women, and you more or less know the set of interventions that are included in providing this service. Yeah? Okay, here basically you know nominator and denominator. Yeah? And that is why coverage works best where we clearly know the need. Here we know the need, it's all pregnant women. For vaccination, we know the need, it's all children under 5. But we have, of course, also other health areas where the need is not so clear, and that is an area where the concept of coverage is more difficult. For example, what is the coverage of acute appendicitis? You know, it's difficult to say if a country performs this number of operations on appendicitis, it covers or not. Yeah? So there is, in that respect, a bit of a problem, but most of the big intervention areas, we have a relatively good idea of what the need is, and the need is our denominator. Now, we have then to answer these questions in order to assess coverage. What is the need? Who is in need? What are the appropriate interventions? Here basically is also linked to the concept of where is the evidence, the link also to evidence-based medicine, and how can these interventions been implemented effectively. Yeah? So there is a kind of background work that needs to take place in order to assess coverage in the first place. Yeah? Now, one argument, not against, but I mean, critical discussion on universal health coverage has been that it's difficult to measure, and I would object. Of course, we don't have the one measurement that gives you easily the universal health coverage for a country. But we have many data on coverage, and even data you find now in international statistics, many of them are coverage data. Yeah? So, for example, coverage of antenatal care, vaccination coverage, coverage of antiretroviral treatment. So it's quite something out there to start with, number one. Yeah? Then, of course, the scope of universal health coverage will not be uniform across the globe, because resources are different and also because disease patterns are different. Yeah? So, of course, we will not have the standard measurement that you do across the world, but there has to be a kind of discussion within countries or within certain geographical or ecological entities and to define what is the universal health coverage for us here. Yeah? But I think this is not, at the end of the day, probably not a disadvantage, but that is probably what could rather increase acceptance and ownership of universal health coverage rather than basically a top-down concept. These are the priority diseases where we focus on. Yeah? Now, we can, of course, also monitor outcomes, a bit following up on the previous MDGs, because, of course, the assumption is if you provide universal health coverage, then we will also improve maternal mortality and other factors. In fact, this has been shown in the past, because there are many countries that have reduced maternal mortality on this globe without ever starting a real safe motherhood program, without having ever had a program to reduce maternal mortality, but just by extension of universal health coverage. Yeah? And we don't have at this stage the one measurement whether one can combine different variables and coverage data into one composite indicator. I think it's doable, but that will be also a lot of academic work and also discussions whether it's useful, whether we should do it, and whether it's doable. Yeah? So this one number where we can, which is comparable to 100 million lives saved or whatever, whether it can basically get this kind of easy handling of this data, that of course, that can be an issue. Yeah? So my conclusions are universal health coverage can be operationalized and adjusted, and it can thus cover a much broader area range of countries, and it's really universal, probably a bit different to the current MDGs. The specific content and scope needs to be defined and is part of a political process, which you can look at advantage or disadvantage. I rather think it's an advantage. And universal health coverage is really basically an immediate expression of the right to health, because it starts with problems, it starts with sick people that have a right to get care, and it does not start with a predefined set of diseases. And I just want to acknowledge the Go for Health Consortium, which is an EU-funded project, and we are mandated by the European Commission and also to advise them how they should steer their course in the post-2015 debate. Thanks a lot.
Thank you very much, Professor Jan. And I would like to introduce now Dr. Rupa Dutt. She's the past president of the International Federation of Medical Student Associations, and she has been involved in advocacy work around the post-2015 agenda, and she will now present how the health in all policies approach is the key for development.
Thank you for the introduction and opportunity to speak here. This morning we've been talking about breaking silos, being intersectorial, and one of the key emerging themes that have been echoed is that we really need to think about how we can have greater health presence in the post-development agenda. I'm going to be talking about health in all policies as a vehicle and tool that we can use to increase the presence of health in post-2015 and sustainable development agenda. But to begin with, I want to start with a short little exercise. I want all of you in this room to just imagine this picture here. There's a school of children in rural Bangladesh. Imagine their hopes, dreams. What comes to your mind when you think of this school? What aspirations would you want for these children? What would be the goals, objectives, targets in education? Now, instead, focus on health. What linkages can you identify with this school, education, and health? Now think about what's below the tip of the iceberg. What are some other issues facing children? Issues such as sanitation, legal protection, disease exposure, instability of food resources, disaster management, and many, many more, all challenge the health and well-being of these children. This example of school children demonstrates that multiple sectors intersect to achieve the ultimate goal of maximizing the potential of children in education. Our expertise is health. When we strive to improve health in settings such as the school, we have to think about how, in the global policymaking context, can we integrate health into other sectors, such as education, and not only via the health goal. It begins with identifying an opportunity. As we've been discussing this morning, in the globe, around the world, we're in the process of creating a goal-oriented, measurable framework for the post-2015 and sustainable development process. The roadmap that's going to be created will encompass several sectors, ranging from food, agriculture, environment, health, education, gender, and many more. The tool that we have in the health community that we can use to ensure health is a core part of the agenda is health in all policies. Health in all policies is an approach to public policies across sectors that systematically takes into account the health implications of decisions, seeks energies, and avoids harmful health impacts in order to improve population health and health equity. It improves accountability of policymakers for health impacts at all levels of policymaking. It includes an emphasis on the consequences of public policies on health systems, determinants of health and well-being. It's simple. All sectors impact health, and health impacts all sectors. So policy should reflect this integration. Secondly, health in all policies is a framework with a variety of tools, such as impact assessments, indicators, and creating health metrics. These all help coordinate intersectorial projects and improve governance. Additionally, the private sector, one that we don't often talk about, also impacts health. The priorities differ when there is a misaligned research and development goal. We have seen environmental degradation, we've seen increase in products with negative health impacts, also limitations of intellectual property transfers, and overall poor health outcomes. Health and policy creates the mechanism to work with all sectors to address this force of the private sector. So let's apply the health and policies approach to one of the proposed goals. This is one of the goals, number 2, empower girls and women and achieve gender equality. It states, prevent and eliminate all forms of violence against girls and women, end child marriage, ensure equal right of women to own and inherit property, sign a contract, register a business, and open a bank account, eliminate discrimination against women in political, economic, and public life. These all would improve the lives and health of women. But we can go a step further and identify areas that are linked with gender and health that support the goal and promote targets and indicators based on that. Some things to consider: accessibility of quality health care. Are women able to access the services that they need? Are they quality services? That could be a sub-component for us to consider. We could also include into this accessibility to safe and affordable family planning. Again, that improves gender equality, but it improves health as well. Other things to consider: healthy life expectancy, expected educational attainment, even income inequality is something that we could factor in. Okay, so another goal that we can look at. This is goal 8, which was proposed: create jobs, sustainable livelihoods, and equitable growth. Increase the number of good and decent jobs and livelihoods. Decrease the number of young people not in education, employment, or training by X%. Strengthen and productive capacity by providing universal access to financial services and infrastructure such as transportation and ICT. Increase new startups by X and value added from new products by Y through creating an enabling business environment, boosting entrepreneurship. So if, again, we go ahead and identify areas that are linked between jobs and health that support the goal and promote targets and indicators. So again, thinking about some other possible areas. We can measure the Gini coefficient of income inequality, the standard of living, the rates of unemployment. We can measure the proportion of GDP spent on health and social services, measure the income loss due to illness, measure rates of disability, rates of access to safety nets, healthcare benefits provided by employers. These are all things that we could integrate into the goal of creating jobs and sustainable livelihoods. We can apply health and policies in this manner across the post-2015 and themes and pillars of the sustainable development. We've heard a great deal about universal health coverage. I'm just going to highlight a few salient points here. System transformation towards universal health coverage illustrates multi-sectorial impact. Health systems make healthy populations. Health systems must be blind to socioeconomic status. Universal health coverage will strengthen economies, improve population health outcomes, and international relations. Strong health systems complement disease-specific programs because they address the social and environmental and economic determinants of illness and well-being. Access to health care and the quality of health services are also equally important. Health systems strengthening through universal health coverage is multi-sectorial. And we're talking about indicators. Some things to keep in mind is that the development of indicators must be disaggregated. It should be disaggregated by gender, age, location, people living with disabilities, educational background, economic quintile, relevant social groups, just really breaking it down so that we really understand what the true reality and picture of what our work is. Additionally, we've heard today, Professor Dinke mentioned the importance of health data, the disparity that exists. We know that more than 25 countries do not keep accurate birth and death records, while others have national electronic health records. There's a big disparity. We need to strengthen our health information systems across the board. And as part of that, we need to have more frequent measures, not just measuring annually, but really learning how to get into measuring monthly, real time, to again have a true picture of what is happening in our health. So, as we move ahead, health in all policies is cross-cutting. There are high-quality indicators and targets that can be set to incorporate health in all policies into the new development framework. The global development community already measures and uses many of these indicators, but does not link them together. Health is the foundation upon which the 3 pillars of sustainable development are unified. Health can be the cross-cutting issue of development through using a health in all policies approach. Thank you.
Thank you, Dr. Rutat. And I would like to open now the floor for discussion and also invite the audience to ask questions, make comments. And maybe while you are thinking about possible questions that you would like to ask and get ready to go to the microphones, I would like to ask a question to Andrew, actually. I see a lot of young people in the audience. Given all this movement, the global tonality of these discussions, do we need to adapt the training that we give to students in public health, other medical professions? Is this current discussion changing the way we teach in public health?
Well, I think a couple of issues there, really. I think conventional public health courses and schools have not been very good about integrating the health in all policies approach that Rupa mentioned, but also integrating public health with these broader sustainability issues. And I think that is quite a big challenge to conventional education and research programs. It's also true that research funders have tended to focus their research efforts in specific silos. So it's been very difficult to get them to fund research across different sectors. And if you don't have research going on, then you don't have academics who can teach with authority about these issues. So research and education, particularly at the postgraduate level, are very intimately linked. So I do think it poses a number of challenges. We are beginning to see signs of change. The Wellcome Trust, for example, has just put out a call for bids for research projects linking health and sustainability, and they had over 400 applications. So there was a lot of interest there out in the community, pent-up interest. They'll only fund a small proportion of those. But it does suggest that some funders are beginning to reorient themselves and thinking more intersectorally. That will bring people together across sectors, and that will create an academic environment in which we can start to teach in a genuinely intersectoral manner.
Thank you, Andy. I think there is a question, if you can just introduce yourself.
University of Melbourne, Australia, for some fabulous presentations. In reflecting on Rupa's beautiful illustration of the interrelationships between health and education and health and learning, I was really struck, Nina, by your goals for Gavi, with your first one being that each child should be able to live up to their full potential, and then the second being that each young adult should be taught and empowered to have a healthy lifestyle. These are fabulous goals. But my specific question related to the language of the second one, and in particular, why the focus on each young adult being taught? Because as we know, so much of the interaction between health and education takes place in schooling, both primary and in particular secondary schooling. So I suppose my particular reflection was, why not each adolescent and young adult? Was there a particular reason that Gavi chose the language of young adult?
Actually, no. But I think for us, we have trouble with the wordsmithing of the concepts, and we find that, it's an excellent question, and I'll bring it back. We're right now in the process of developing our strategy for 2016 to 2020. I encourage everyone in this room to go to our website and input on what you think our vision should be in the next period. So we are in the process of testing language. I think we struggle with what to call the 9 to 13-year-old girl. I guess you're sort of the man who can answer this question probably the best on the panel, but in some treaties they're called a child, and some they're an adolescent, and some. So what we mean is that category, and particularly around the human papillomavirus, and making sure that when we give a girl that vaccine, and maybe someday there'll be a recommendation also that we give boys that vaccine as well by WHO, that we're not just giving them the vaccine, but we're giving them sexual and reproductive health education, HIV prevention, tuberculosis, vitamin A, whatever the needs may be. So
if that's the case, then I would certainly strongly urge greater utilisation of language of adolescents and young people, or adolescents and young adults, because again, as your example highlights, if that is the intent, then so much of these health risk behaviours actually have their onset in the early adolescent years, and young adulthood is way too late.
And then how would you address the sort of definition of child being under 18 by some and by some of the treaties and documents?
Look, I think that this is a much broader challenge for the field. I think it's a very important question, and I think it behoves all of us to refuse to use the definition of childhood for the under fives. And in the global health community, I think it's been our universal problem that we have inadvertently define childhood as being under the age of 5 because of the overwhelming focus on, obviously, the high rates of under 5 mortality. Now that we've got the successes that we have seen there, clearly the movement now is much more towards how are we achieving and building on those investments that have been gained from improved survival, and investment obviously in the second decade is required. So on one hand, I'd urge us to reclaim the language of child as referring to under 18-year-olds. But I also think that the language of adolescence, recognising that that's WHO definitions 10 to 19, the languages that we've been using in the Lancet series on adolescent health is adolescents and young adults from 10 to 24, recognising a huge span of development. But I would also agree that then that peri-adolescent age, the 9 to 14, if you like, or if we go down to 9-year-old. But certainly, as I think you're articulating, that 5 to 9-year-old age group demographic has been completely missing in terms of any of our global data collection systems as well.
Thank you for your question. If there are any other questions, do not hesitate to take the floor. Yes, please.
Good morning. Thank you so much for your remarks this morning. My name is Michelle Brooks. I'm with the Global Network for Neglected Tropical Diseases, part of the Sabin Vaccine Institute. And I couldn't agree more with the cross-sectoral integration of health among other development initiatives, and I wondered how the panel would say is the best way to move that agenda forward as these negotiations are underway for the post-2015 development agenda. Thank you.
Who wants to comment? Andy?
Well, I think really one of the challenges is to see if we can develop consensus indicators, as I alluded to in my talk. I think the challenge then is to have indicators which reflect the concerns of us in the kind of public health sector, but also reflect the aspirations of people in other sectors. And I think that what gets measured gets attention. So the selection of indicators which combine these two facets is going to be very important. I mean, how one does that, I think it's important that public health, the public health voice is heard. For example, at the consultation sessions of the Open Working Group that are coming up, there's a number of these coming up in the next few months on specific issues. It's important that public health is represented in those discussions. Also, the ideas are fed through the various technical advisory groups. There's a Sustainable Development Solutions Network that Antoine and I are involved with, but there are other groups as well. So I think we have to feed these ideas in through multiple routes. And hope that some of them at least take root, because I think that will be absolutely crucial in developing this very integrated agenda. And it means also, I think, someone like Carlos Dora, I think, is in the audience, may want to comment, but also facilitating cross-working between different UN agencies. So, for example, UN Habitat does a lot of work on the built environment, on housing, helping to facilitate the inclusion of health-related indicators in some of the indicators that are being developed around slum housing would be a step forward, I think.
Thank you. Yes, Fred.
I think also we need to look at how how we implement this at the country level. You need to bring all these groups together and to make sure that we have a plan that involves all the sectors. But the current approach is that we have interrelationship with several sectors, and support to those sectors are fragmented. It's a real challenge if you don't get these groups to work together. If you go to the country level in most developing countries, if the health ministry calls a meeting to get other sectors to be involved, then they expect that the health ministry will fund it. And then what happens is that it doesn't get done because the other sectors are not provided with the resources to be able to address the common issues that face all of them.
Thank you. Other comments from?
Any further question? Please think about things you would like to ask. Yeah, please.
I'm Peter Chung from Taiwan, also on behalf of APAC, Asia Pacific Public Health Alliance. I have a question regarding these targets and more targets, but we are having problem on the soldiers and which is going to fight in the field. I remember we talking about health human resources continuously, but I'm wondering after 2015 or now, are we calculating how many work we have to do and how many people we are ready in terms of medical school? I know there's a lot of brain drain still ongoing and there's a lot of shifting of the jobs between different health professions. So would you like to comment on, are we ready to make these soldiers available? Thank you.
Would like difficult question.
So I completely agree with you. I think this is the real challenge. The real challenge is how this plethora of targets can actually be organized in such a way that we can both implement and we can also track progress. I think this is really critical. And maybe in putting these new SDGs together, we need to see how we can look at possible goals that will include some of the areas that we're talking about. And I think that is where the intellectual discussion must be focused, because we're doing some on education, we're doing some on health, we're doing some on gender, but somehow we need to find ways in which we can reduce the number of these goals and targets to make sure that the countries are completely not overwhelmed and not actually beginning to find whether they can be part of this process at all.
I was interested by your use of sort of military language in that question, because I think for me, also sort of the idea of redeploying the soldiers in medicine, for me, it's a very medicalized approach. And I think, you know, I was struck last night. I come from the public health sector. I'm not a doctor, and I'm sort of proud of that because I believe that the public health agenda and carrying it through is a citizen movement, and it doesn't require doctors. I think we moved in an area that was a little too far on the medical front, and I think a lot of what we're now teaching in public health is that you actually don't need to be a doctor to make a difference in this field. So I think getting to the next stage is about deploying everyone, every citizen, every mom, every dad, every grandma, every grandpa, to make sure that we move forward. And on the question before about kind of also around motivation is I think in the health field we need to do a better job of explaining why it's important to everyone what we're talking about and why there are linkages and helping to make those linkages more explicit. Often we sort of talk in our own world with our own acronyms and we don't explain to people, for example, that STAC slide I showed, mislabeled as a Bloom slide, shows that if you improve immunization and you immunize kids, you're going to have significant residual economic sustainable development. So I think we need to change our language and also change our attitude about kind of who are the soldiers in the field.
Yes, maybe the two last comments, one from Albrecht and one from Andy.
I mean, that is a real challenge, and whether we look at them as soldiers or as health workers, let's now not get lost in how we call them. But one thing is clear, that there is also quite a field to improve how medical professions work together. And there has been, especially in the field of maternal health, this movement of task shifting, which goes well in some countries, not well in others. Because, of course, also professions defend their territory, doctors versus midwives, and so on. So I think there is, if there would be a more, let me say, common spirit, rather than putting professional interests first, there is quite some efficiency gain to make. Another point is that, and I will want to build on that discussion on adolescence, that a lot of health work is not performed by health workers. It takes place in the family, and I think there we could also be more effective if we would focus more on teaching health and on health issues in schools and to increase health literacy in populations.
Well, just to add really to that, I think in relation to universal health coverage, there are some very encouraging developments at the country level. So, for example, in a country like Ethiopia, they've trained over 35,000 health extension workers, 2 to each community, who are trained for a year and can deliver basic preventive, promotive, and even some curative health services. We're seeing, for example, in Pakistan, a big scaling up lady health worker program, 100,000 lady health workers, and a number of other countries where they're adopting this so-called, I don't like the word task shifting very much because it assumes that doctors are always the best people to do things, and they're not always the best people. But I think a sort of community health worker, primary healthcare approach is being scaled up in a number of countries, and we need to look and learn from those examples of where it's being done on the ground. And we need, obviously, not all of it's successful. There are limitations as well, and we need to look at them in a kind of honest and balanced way. But there are 2 other areas, I think, where we need specifically to build capacity. One is around health information systems and vital registration, and still there are many countries that don't have a very good indication, actually, of death rates. And if, for example, we wanted to go to measure life expectancy or even healthy life expectancy, many countries couldn't provide that data very accurately. So we need to build up capacity in vital registration, in basic epidemiology and health information systems. And then the third area really is the one that we've talked about, which is the whole intersectoral development. And that's where I think public health needs to reach out to schools or universities that train urban planners, that train architects, that train engineers, train agricultural scientists. And we need to be teaching those and working on joint teaching programs between these different disciplines in public health.
Okay, so thank you. I would like to thank very much all the speakers of the panel and the audience for your attention, for your questions also. I think there is still a lot of work to do, and unfortunately, I think we have finished. I apologize because we have to close the session. Yes, maybe this bottom-up approach, which is still lacking a little bit in all this very high-level process, is something which has been highlighted, and I think the urgent need to involve much more the population, the citizens, as you mentioned, is clearly something which is very important. So thank you, everybody. Thank you again for your commitment in this session, and have a good day.